You are listening to the Nottingham Recovery Network Podcast, where we tell true stories of people who've walked the path of recovery and hear from those that supported them every step of the way. Real people, real recovery, real hope.
Welcome to this edition of the Nottingham Recovery Network Podcast. This week I'm joined by Tickle, who is the consultant clinical psychologist for Nottingham Recovery Network. Hi Anna.
Hi.
Thanks for spending a bit of time with us today.
Thanks for inviting me.
That's all right. Thank you. So I guess today we're just going to talk a little bit about how psychology and the various models fit into drug and alcohol treatment, because the other podcasts we've done, we've sort of concentrated quite heavily on the clinical side of things and methadone reductions or methadone as a OST. But for me personally, I think the therapeutic side that psychology can bring is equally as important as the clinical side.
Yeah.
So as the lead psychologist for us, what kind of services are on offer from NRN?
Yeah, I think you're right. Kind of, you can have the clinical side, you can have OST, but actually, if you're not thinking about somebody's psychology and where they're coming from and what they want and what's important to them and all of those sorts of things, then it's essentially you're not going to be able to deliver the clinical service as well as you might be able to. So the main aim of having psychology in NRM, which is quite new, so my post was established about 18 months ago, and RASDAT have a psychologist, but that's also kind of fairly recent. The real aim is to help all of the staff and everybody who's working more directly with people work in psychologically informed ways, build psychologically informed environments so that they're able to best meet the needs of people that need to access the service. So we've got some people obviously who are very able to come in, ask for help, put the advice or put the kind of guidance into practice very easily. And then we have a lot of people who are maybe much more ambivalent about coming into treatment or don't even kind of know how to navigate their way to treatment. So that's really where psychology comes in to start with, is thinking out it from the perspective of people that use the service, helping staff to really build their kind of, our staff are very empathic, but really think about where people are struggling to make use of what's on offer, help really build empathy about why that might be and think about what interventions might help engage that person more readily and not put the blame on the person for not engaging, but thinking, well, what can we do differently? Well, I'm not expecting them to change.
So I've been lucky enough to work with the psychologist Dr. Buckley in RASDAT for a couple of years whilst I was there. And I think originally we thought Dr. Buckley was coming in for the clients, but it sort of really quickly transpired that it was actually an education for us as key workers. When you say it's new, and you mentioned psychologically informed environment, so PI, I've heard a lot about.
Yeah.
Where did the need arise, or what was the real reasoning for it coming in?
So I think there was a time going back probably a couple of decades where you had a lot of psychologists who worked in what were then more called addiction services. Some changes in kind of commissioning processes and it becoming more of a it left healthcare services that used to sit within the NHS. Maybe psychologists were more usually in teams in the NHS. And then as commissioning changed and it moved more to a third sector, we saw psychology as a profession kind of move away from addictions because third sector organisations often weren't kind of employing psychologists because they're relatively expensive. But I think actually increasingly, and probably the Charles Black report as part of that, increasingly it's recognised that, services need to be trauma-informed, they need to be psychologically informed. And so we're seeing a growth, not just locally in Nottingham, but actually nationally, of psychologists coming back into services and that being more of an expectation that, psychologists bring theory and, and practical experience that can then help the staff to do the work in the best ways that they can possibly do it, as well as staff being supported. So, some of the work is very, very challenging in terms of hearing lots about trauma people have experienced or are still experiencing. Obviously, if you're using substances a lot and or homeless, you're going to be experiencing or at much higher risk of trauma. So helping staff to kind of manage their responses to that, helping them to think about how they support people to cope with the difficulties they're having. And of course, we see a massive overlap in mental health problems and substance use, because substances are a good short-term way of coping with a lot of mental health problems, but also they can lead to other problems and then exacerbate other mental health problems. So I think also having that kind of knowledge around mental health and understanding behaviour is where psychologists can come in. And I suppose, I think you're right that often the assumption is we'll just see individual people back to back for therapy, but we could do that all week as a psychologist and not make very much difference to the service, and also not make very much difference to the individuals, because you need much more than therapy. You've got to have that recovery capital, you've got to have the social connection, you need good, consistent support. And actually, I know that most of our workforce can do brilliant work with people, build really brilliant relationships with people, build on lived experience, all of those things that make a good substance use practitioner. The psychology is there really for the trickier moments, I would say, and the trickier kind of behaviours that people might come with or bring, or also helping staff kind of manage how much they get involved when they see someone who's in real desperate need and they want to do as much as possible for that person. Sometimes that's helpful, but actually sometimes you can end up wanting it more than the person wants it themselves, or trying to impose stuff on people. And that doesn't really help recovery. It usually puts a distance between the person and services. So it's having an eye on those sort of dynamics that can play out, and
So trauma is something we hear a lot about in service, and it might be a too big a question, but and in the media and stuff, there's a lot around trauma. There's that guy Gabor Mate. I quite like his takes on it. But briefly, if possible, what is trauma, and how does trauma become a part of addiction or a lead up to addiction?
So when we're talking about psychological trauma, and often people are thinking about post-traumatic stress disorder, PTSD, you've experienced at least an event, but it might be a whole set of circumstances. So, it might be a one-off incident, and actually people can recover fairly quickly from a one-off incident that's traumatic, so long as they've got good support in place. Often people who are accessing substance use services have experienced the whole set of circumstances. So adverse childhood experiences, or ACEs, gets talked about a lot, but essentially parental substance use, parental imprisonment, domestic violence, abuse, neglect in childhood are often in the backgrounds for people who've, who come into contact with substance use services. And essentially those events are things that leave you fearful for yourself, fearful of death, fearful of kind of mistreatment by other people. And so not trusting, being on the lookout all the time. So in terms of how trauma kind of manifests, makes you really hypervigilant. So you're on the lookout for threat all the time. You might find it harder to kind of regulate your emotions and stay kind of present in the moment, respond kind of proportionately to things. So you might find that you're quick to anger, or you have big mood swings, or other people might describe you as aggressive. You might not feel like you are. You might feel like you're kind of protecting yourself. So there's the kind of hyper arousal, that's the agitation and the on the lookout stuff. Or you might experience a lot of hypo arousal, where you just feel numb or cut off or very flat or worthless. And I think different substances can play different roles in helping you cope with trauma. So sometimes it's about just wanting to forget what's happened to you and kind of disconnect from that. Sometimes it's about trying to lift you up if you feel really low and flat, or to feel something. So I guess that's also why psychology is helpful, because the same drug might serve, even though we know what effect it's meant to have, whether it's upper or downer, or the same drug might have different functions for the person who's using it. And being able to think about, why are they using this? What does it actually do for them in relation to their trauma symptoms is really important. There's also some evidence that people who've experienced kind of interpersonal sexual trauma might use some drugs to try to almost get more contact with the experience that most of the time they're desperately trying to cut off from. But they want to be able to kind of process it. And I guess, we're seeing psilocybin trials for depression and other kind of psychological problems. So, drugs have been a way of coping with trauma for a long time. Sometimes it's very workable for people and it might just help you manage your emotions. Then it might become unworkable and you get caught in kind of addiction, and it's less of a choice anymore to use or not use.
It's sort of that they do exactly what they say on the tin, drugs and alcohol and substances in general, but it's not a long-term solution.
Exactly.
I think it's interesting what you're saying about those feelings of trauma and, constantly being on the lookout, because as a person in recovery myself, those feelings sound really familiar to the time I was in addiction, never mind the trauma stuff that led up to my addiction. It's so it seems like a real cycle of events that people just get stuck in, maybe.
Absolutely. And then of course, if depending on, some people will sit at home on their own, won't they, and not necessarily be in contact with other people while they're using. But for lots of people, we know use might become social, or it might be social to start with. But then depending on what you're using and in what circumstances, you might become more and more vulnerable. And obviously you might be experiencing financial pressures that might then lead you into sex work, or, crime, acquisitive crime sort of fund. So it's not hard to see how there's a trajectory for some people of the trauma leads to the substance use to cope with the trauma, but then opens up the likelihood of much more additional trauma because you become vulnerable through needing whatever it is, whatever substance you're using, and or the money to be able to, or the means to be able to acquire it. So it's not hard to see how that can be a spiral for some people that then might feel really hard to come back from.
And I think with you mentioned ACEs, so adverse childhood experiences, and some people, like I've heard big T and little t mentioned, and some people can deal with a traumatic event if they have that support network around them. And I guess then some people haven't had that support around them and then will turn to a substance as a means of support.
Yeah, absolutely. And even when you do have support around you, and this is part of the reason we don't do as much kind of individual work as people might expect psychologists to. Like, unfortunately, there's nothing a psychologist can do that is as immediately effective in terms of changing your mental state as a substance. If you want to forget, if you want to block out, or if you feel massively socially anxious and kind of hypervigilant because of past experiences, and then you have to be in settings where there's loads of people around, then substances will do that. People talk about Dutch courage, don't they? It's kind of an extreme version of that for some people, or just a blocking out, or it ties into all sorts of kind of core beliefs that people might hold about themselves as well, about whether they're worthwhile or, sort of deserve good things, or, so there'll be a complex sort of interaction for everybody in terms of how the substance use relates to their experiences and their mental health, or just like, not even, I don't mean like diagnosable mental health problems, but just their sense of themselves, their belief about themselves, other people, the world. It'll be quite a complex interaction that plays out differently for different people, but having a psychologist around can help sort of unpick that a bit.
The models that you teach if you like, to the key workers. What are some of those you mentioned? ACT?
Yeah. So acceptance and commitment therapy, that's probably like my preferred model. And that's interested in how experiential avoidance is about trying to get rid of that internal stuff that shows up that we don't want, but unfortunately is just part of being human. So memories, images, unpleasant thoughts about ourselves, other people, anxiety, anxiety about the future, rumination about the past, all of that kind of internal stuff that is human. We don't really want it. And substances are great at kind of blocking it out. And ACT teaches you to be able to allow that stuff to be there. The acceptance bit is like the willingness to have the unpleasant stuff, but also to be able to kind of step back from some of the thoughts that might hook you. And, you might believe they're fact. So if you think you're worthless, you might believe that fact, but actually that's just stuff your brain chucks at you. So it's how do you sit with some of the uncomfortable stuff, but step back from it, learn to kind of notice it rather than respond and react to it. Be more in the present moment, think about your values and take action that's in line with what's most important to you. And ACT sees people not as ever sort of damaged or broken, but just as getting stuck. So some of those sort of cycles we've talked about, we wouldn't think there's anything wrong with the person. They've just got stuck doing the best that they can with the resources that they've got. And ACT is about kind of unsticking things by starting to notice those patterns and use and develop skills to do things a bit differently. So I like it because it is like, I guess CBT is very good for some people, some problems, some of the time, but CBT gets into challenging thoughts. And for a lot of people, actually, their current views of themselves or how things are, you can see where they're coming from. They're not necessarily that irrational. So ACT is not about getting into challenging your thoughts. It's about saying they're going to show up anyway. And sort of old stories are going to keep showing up and kind of trying to direct your behaviour. But we're not going to get into arguing with them or challenging them. We're going to think about what action can you take. Every moment is a behavioural choice. And you're not any of the stories that you tell about yourself. You are how you act day to day. And so you can always build whoever you want to be through your choices. It's also what's known as CANS diagnostic. So it's not specific to any mental health problem, or it's in the national guidelines for treatment of chronic pain. And obviously lots of people who use substances do that to cope with pain. It's been shown to be effective across cultures for lots of mental health problems, substance use, grief, other problems that might be related to substance use. So that's why that's my preferred model for NRN. I think also because it really resonates with both staff and people that come into contact with it as treatment option.
So as staff delivering, I've done your ACT training and I'm not blowing smoke. I really enjoyed it and found it really useful. But some services, I've had personal experience of this.
Yeah.
So that if you want any sort of therapeutic input,
go
away, don't drink for 3 months, and then come back and see us. How come NRN
because it's not a very helpful approach. Because, essentially we would see substance as the coping strategy. So if you just strip a coping strategy away and say, go away, don't drink, don't use anything for 3 months, what is the person meant to do to cope with all the stuff that's going to show up that they've been busy blocking out? So I think that's all all the psychological stuff, all the unpleasant internal stuff, but also I know people that have been through detox and suddenly find they've got sexual functioning back after a long time, and it's really overwhelming, and physically you're going to change, or you're going to start noticing new stuff if you've been using for a long time and then you stop. So if you send someone away for 3 months and say, don't do the thing that helps you cope, and then come back to us, it leaves somebody actually really vulnerable and potentially vulnerable to trying other things to cope, which might be even more kind of risky, really. A lot of people use substances actually it's a problematic level in one way for them, but actually it's kind of safe in the sense that they do know what they're doing, they know how much to use, they've got a sense of how to use in a way that fits with sort of harm reduction. If you just take all of that away, then actually someone's likely to be really overwhelmed psychologically and potentially physically, and that could be really sort of dangerous. It's also just not very humane, I think, in terms of it's not how you build trust or rapport, and it's quite punishing, isn't it? It's like we're only going to give you what you need if you change your behaviour. It's just not. It's like I don't want our services to be contingent on somebody having to stop doing the thing that they need help with.
Yeah, I remember being told that by a service, and it's like, well, if I stop doing what I'm doing for 3 months, you don't need your service. But I think I can't stop in 3 minutes.
Yeah. I think the other thing that's really important to say is there's very clear national guidelines. So the Orange Book, as it's known, the treatment use kind of guidance is very clear that somebody should not be excluded from a mental health service because of their substance use and vice versa. And then there's also specific NICE guidelines. So that's National Institute of Care and Health Excellence. They have specific guidelines so around people with severe mental illness, as they call it. That's a big term I use, but severe mental illness, again, should not be kind of prevented from having access to mental health services because of substance use and vice versa. They should be able to come to substance use services without being in mental health treatment. And what's really clear is that the care should be coordinated and joined up so that people are getting both at the same time. But we know it's not what happens, but that is written into national policy from the Department of Health. So that's another reason that we want to be able to offer both at the same time.
Yeah. And I think, again, just with my experience working here is I've seen in the last few years that mental health unwellness is on the rise. And I think we're seeing more and more substance users who are suffering with their mental health as well. Why do you think that is? Is it new drugs? Is it different drugs?
I think it's probably a complex range of things, isn't it? I think I would start with poverty, increases in social pressures, the decimation of services that might support people sort of further upstream, as I would think about it. So, I like that metaphor of you might be downstream pulling the bodies out of the river, but you need to go upstream and find out how they're getting in there. And I guess substance use services are often, we might be working with people early-ish when they realise things are becoming problematic, but often we're working with people who have, reached a point of combinations of substance use, homelessness, violence in relationships, offender. We're so far downstream for a lot of people. So I think I'd start with that kind of decimation through austerity, and there's fairly clear kind of evidence around that. But then I also think, technology makes stuff much more accessible, doesn't it? I think certain things become very normalised and less of a big deal, I suppose. And I think there's got to be a role of influence of social media. And, I've seen TikTok cocaine influencers or whatever. It's like quite scary stuff, kind of essentially glamorizing use. And some people will use cocaine and never come into touch with services, and that's fine, isn't it? If it's workable. ACT has this idea of whether something is workable or not. For lots of people, drug use is workable and they'll never need treatment. But I think glamorizing it, if it feels workable for you, doesn't consider or attend to the fact that for lots of people it might not be workable but might seem quite tempting.
Yeah. And those TikTok guys, they're also not living in a car park.
No, absolutely.
They're doing okay for themselves.
They don't have sex work to fund their use. So,
some of the more recent drugs that have come through, like in Nottingham, there's a big mamba problem. Anecdotally, our NMPs here and key workers seem to think that's having an effect on people's mental health. Do you think that's specific, or do you think it's just a bit cyclical?
Yeah, it's hard to know, isn't it? And I think things come, like, yes, different drugs will come and they will have different influences, and people won't know a new drug. It takes time, doesn't it, to get to know a new drug or what effect it's going to have.
Yeah.
And how you individually and whether you can use it kind of safely, whether it does meet what you're looking for out of drug use. I suppose also, there's a lot of unexpected nicotines around, and we've seen a massive increase in drug death as well, haven't we? So there are trends and changes, but I think it's really hard to separate out the drugs from the social context stuff. So, resources are less available. We've had recent riots that are related to racial hatred. There's lots of social factors that are going to be influencing people's mental health as well, that might influence whether they seek out drugs or different drugs, and also how they might respond to them. So I wouldn't say that the drugs themselves don't have any effect on people's mental health. They absolutely do, and so does withdrawal. And I suppose that was the other thing to hold in mind. Sometimes people's mental health is actually on a better level while they're using, and then if they try to stop or they can't access drugs anymore. I mean, that's the same for prescribed mental health medications as well. Withdrawal can be really, really difficult. But I think it's hard to know what the interplay is, isn't it, with all the social stuff that's going on at the same time.
Yeah. I think something that's always confused me a little bit, and it's probably a really simple question, but psychology and psychiatry.
Yeah.
What's the difference?
It's a common question. It's fine. So psychiatrists are medically trained. They're medical doctors. Psychologists are called doctors, but we're not medical doctors. We just have done a doctorate in psychology. And psychiatrists can prescribe medication, but psychologists can't. So they're the sort of key differences. I guess also, as a general rule, although not a hard and fast rule, psychiatrists tend to diagnose mental health problems more than psychologists. Psychologists get involved in autism or ADHD diagnoses and dementia diagnoses, but on the whole, we leave mental health diagnoses alone. Lots of psychologists don't believe in mental health diagnoses. And what we're interested in is kind of really formulating, so trying to understand the person as a whole, not just attach a label. Now, that's not to say there's not lots of good psychiatrists who don't also formulate, because there are, but we tend to not get so involved with diagnosis.
So a psychologist will look at the person and not say, oh, this is your problem.
Yeah.
They more say, this is who you are. Let's look at how we can help you live a productive, nice, fun life.
Yeah. I mean, psychiatrists are doing that as well. They're trying to help people's lives be better. And, I'm not anti-medication at all. Medication does wonders for some people. And psychiatrists are interested in people's developmental history, how they got there as well. Well, we just have very different trainings in terms of what it is you look for and how you kind of respond to it. So I'm not anti-medication, but it would never be my first sort of go-to. I'd always be thinking about what kind of psychosocial support does somebody need. I would see medication as potentially being helpful to manage symptoms, but not getting to the underlying cause. And that's where psychology, I think, can help people work with, well, what's going on psychologically here, and how do we make some difference to that will help improve your sort of well-being.
A question I ask everyone, and we sort of round off on this, and you go as deep as you want, but I have my reasons for doing my job.
Yeah.
Mostly shame and guilt related. But
whatever brings you here.
What as an incredibly well trained person, what draws you to working in substance use services? Because sometimes it can be quite thankless, sometimes it can be really hard, and you could be sat on a nice leather sofa, I imagine.
Oh no, that's not me.
But what keeps you coming into work, I guess, is my question.
I think for me, I like an underdog, and I think substance use services have been an underdog in terms of psychology. I think psychology has been late to the party with homelessness, substance use. I think there's a lot more we could have done as a profession a lot earlier. I think in terms of the day-to-day stuff, I love the people. I love the variety. I think there's so many different people. Addiction touches everybody, doesn't it, one way or another? So I think I love people. That's the nature of the job. And the range of people that you get to meet, both in terms of people accessing a service, but also people who are working in services, is just amazing. And everybody's here wanting to make things better for people. And I think that's the thing for me, is we're often working with people who have been excluded elsewhere. And I think psychologists should use their privilege to not exclude people and help everybody, and think about how we reach people who can't pay to sit on a fancy leather sofa. And I guess personally, I have friends and relatives who've died of alcohol use or drug use, and so it's always kind of been around. I don't think that's sort of driven me to the work. I think it's there and in the sort of background of it's relatable, and one. I also think there's something about, like, socially, particularly alcohol. We sanction the use of alcohol, and I won't go on a rant about capitalism, but a lot of people make a lot of money out of alcohol, and that doesn't really make sense to me, because it's probably one of the most dangerous substances people can use. So I also think there's something of like responsibility of helping kind of mop up the consequences of that. I don't drink myself and don't even think either. I did used to drink. I quite like to drink, not in a dependent way, but in a more bingy way. But I think I've been really lucky. I was just able to sort of stop that, because I reached a point where I was training and qualifying at a time where social media and smartphones were becoming a thing. And I knew I probably wouldn't hold on to my professional qualification if I carried on. And I think I've been really lucky, because I just made a decision and that I just stopped, and it was very easy for me. But I know for lots of people it's not, and I've got the knowledge and skills that can help people get to that point, and I'm definitely healthier and a lot more boring and sensible for not drinking, and I can help other people be more boring and sensible, but hopefully live more fulfilling lives using my knowledge. So that's what brings me here.
Thank you. Thanks for spending some time with us. That's a lot to think about. And thank you for everything you do.
Thanks for having me.
Thank you for listening to the Nottingham Recovery Network podcast. If you or someone you know are looking for support with their relationship with drugs and alcohol, we are here to help you. Visit www.nottinghamrecoverynetwork.com for more information.